Hi everyone, welcome to another Wednesday VMR. Sharmin here. I'm so excited to finally discussing with one and only Kirtan. Kirtan, we're finally doing this. How are you doing?
Yes, good evening, Sharmin. Thank you so much for making this happen. I mean, friends, you won't believe that Sharmin will text me 3 months ahead of time asking that, hey, Kirtan, how is your schedule looking in August? Can we discuss? I'm like, I don't know what I'm doing in August. And finally, when we did made it happen last time, Sharmin couldn't join because she was so busy on the service. And then Elena had to jump in. And then today, actually, we were not sure because I was under the impression that maybe I would be working at the hospital at this time, but fortunately, it worked out well that I still don't have those privileges to work. Maybe I need to wait for one more week. And that worked out perfectly that I'm getting a chance to discuss with Sharmin after probably 3 or 5 years. So I'm super excited. It's going to be a great case. And I'm also very excited because we have a new friend who is joining us for the first time to present the case. So maybe, Jomar, do you want to introduce yourself?
Yeah, hi everyone. I'm Jomer. So it you could say it as Homer or Jomer. And I'm a GP from Manila in the Philippines, and it's my first time to be on Clinical Problem Solvers, and I'm really excited to share this case with all of you guys. Yeah,
Amazing, Jomer. Welcome.
yeah.
We're so excited to have you. I'm so excited to learn from you and Kirtan. Big shout out to Anmol Pri and Bayan for doing the teaching points and scribing today. If we can get the board up, then we can get started. All
All
right,
right.
Jomer, mic is yours.
Sounds good. Okay, so I'll start with the first aliquot. We have a 65-year-old male coming in for vomiting. So this patient was previously well until a day ago when he suddenly began to experience multiple episodes of non-bloody, non-bilious vomiting associated with nausea, abdominal cramping, lightheadedness, and generalized weakness. So he said that he had eaten homemade soup before the symptoms started, but that on the morning of, he had normal bowel movement, non-bloody form stools. He denies any sick contacts or recent travel. He denies any starting any new medications recently. For the review systems, he denies fever, chills, syncopal episodes. He doesn't have any chest pain, shortness of breath, diarrhea, constipation, hematochezia, melena, hematuria, and dysuria. And I'll stop right there for now.
Perfect. Thank you so much, Homer, for presenting the
Mhm.
first report. And we can say that your experience as a wonderful GP is showing up here, that you are presenting it in such a lucid way that we were able to capture all the information that we need to discuss. So we are dealing with a 65-year-old gentleman who is presenting with acute onset of GI symptoms, we can say. There is some abdominal cramping, there is some nausea, there is vomiting. Now, all of this started happen after patient had some soup. So first and foremost point I wanted to make, and I think we made this point recently on VMR as well, that often patients try to attribute the onset of symptoms to something which is very well describable. Like, it is also possible that maybe the vomiting actually started when the patient was brushing the teeth. But since brushing the teeth is something which happens every single day, maybe patient won't remember it. But eating a new soup or like drinking a new soup is something which is a unique event and people can remember it. So although we should always try to link it with like something which could be food poisoning from the soup, but we also have to remember that maybe it's an entirely unrelated process and you have to keep your mind open and evaluate the vomiting as such. So what is the general approach to vomiting? So there are so many possible causes of vomiting, but the big buckets are, first and foremost, you should think about the metabolic causes. So I think this is something which we have discussed on VMR very frequently. Okay? Just imagine that if you get basic labs on this person, what are the things which you can see? Maybe you will see hyponatremia in BMP. Hyponatremia can cause vomiting. Maybe you will see hypercalcemia that can also cause vomiting. Then you see some acidosis, low bicarbonate, and down the line, if you prove that this person has ketoacidosis, and ketoacidosis is another very common cause of nausea, vomiting, abdominal pain. Similarly, if you think about you will get the basic chemistry, you will get the liver enzymes, liver profile. So acute hepatobiliary disorder, be it hepatitis, be it cholecystitis, they can end up causing nausea, vomiting, right? So you could start to figure out that there are so many metabolic causes which can end up causing vomiting. The second big bucket is the toxic causes. So as in our case, since all of this started after drinking a soup, and if it's true and related, then you could imagine that what are the acute infections which could do this? So sometimes things like staph, things like bacillus infections can end up causing acute onset nausea and vomiting. So those would be the infectious things. And then once we move beyond this toxic metabolic category, we go to the anatomic approach, that how do you get the vomiting, right? So vomiting happens through the reflex, and that reflex usually originates from different parts of the body. So for example, if your GI tract is irritated from mouth all the way down to the intestine, the reflexes can be relayed back through the vagus nerve all the way to your brainstem. And in the brainstem, in the medulla, you have this chemoreceptor trigger zone where all the information is relayed, and then brainstem replies back and sends the signal affecting the respiratory muscles, affecting the muscles of your deglutition, and that's how the act of vomiting happens, right? So anything which could be wrong with the GI tract can end up causing vomiting. Now, what could be something which can happen this fast, and what is something which we must not miss? So I think any kind of obstruction, so things like acute esophagitis complicated by obstruction, acute gastritis from, let's say, ulcer complicated by gastric outlet obstruction, or small bowel obstruction. So any kind of obstruction should end up causing nausea and vomiting. So that is anatomical approach for the nausea and vomiting. The other possibility is that where else that reflex can come from. So apart from GI tract, even the vestibular apparatus relays the signal to brainstem for nausea and vomiting. So let's say if down the line we come to know that this person has been experiencing some kind of ear pain, some kind of ear discharge, then you could imagine that maybe the vestibulocochlear apparatus is contributing to nausea and vomiting. And then if we go in the brainstem itself, that what can happen in the brainstem which can directly trigger the nausea and vomiting. So people can have, let's say, acute ischemic event in the brainstem, and any kind of brainstem stroke can cause nausea and vomiting. Any kind of mass lesion which has been sitting there for a long time, but now acute change happen. We know that masses can enlarge, masses can undergo infarction, masses can undergo hemorrhage. So brainstem structural pathology can do it. And then the final part of the reflex arc is that your medulla is under the control of higher centers, right? Like your CNS. So if anything happens at the level of cortex, it can relay the signal to the brainstem and it can modulate the vomiting. And the best example of this would be something which we should not miss is the intracranial catastrophe. So any pathology which would cause increased intracranial pressure, be it acute infarct, be it abscess, be it a venous clot in the CNS, all of them can raise the ICP. And once the ICP goes up, you can end up causing nausea and vomiting. So this is like the basic framework. And once we get the more past medical history, once we get the more data, we can tease out these individual entities. And maybe I can ask Sharmin really quick. Sharmin, anything that you would add to this approach?
Oh, I just love listening to you discuss, Kirtan. So thoughtful, so thorough, beautiful differential and approach to kind of like nausea and vomiting. As you mentioned, is like so broad. So I really loved how you like made it into specific buckets and walked us through that. And yeah, Kirtan always with the poetry. I totally agree. Well, I have very little to add, and just to kind of summarize what you were saying is that if this patient is like coming to me with like one day of like nausea, vomiting, abdominal cramping, I think the abdominal cramping puts a focus a little bit on the abdominal processes or whatever that is affecting that. And kind of as you mentioned, like kind of the no misdiagnosis are like kind of the obstruction, the itises, and perforation. And I think like the other thing that I would just be always worried about in someone who's presenting with like kind of nausea, vomiting, kind of abdominal cramping, just to make sure you're not missing any cardiac etiology, any vascular etiology that is like a fair mimicker of it. And oftentimes, as you all have heard me talk, like I often live in the world of like, what are my no misdiagnoses? And in addition to kind of like intracranial processes that Kirtan mentioned, that hopefully will be not this patient who's like coming in to see like Jomer as a GP. But the one question that oftentimes I find that you can ask is like, are they passing any gas, any flatus, in a sense that like, are we really dealing with any obstruction? So I think like, yeah, hearing a little bit more background information would be really helpful. Back to you, Jomer.
All right, sounds good. So his past medical history includes hypertension, hyperlipidemia, type 2 diabetes, and transient ischemic attack about 10 years ago. His list of medications is relatively long. He is on amlodipine, lisinopril, rosuvastatin, metformin, pioglitazone, semaglutide, dapagliflozin, and aspirin. He lives a relatively sedentary lifestyle, so he's retired for about 5 years now and mostly stays at home. He does not smoke, drink alcohol, or use drugs recreationally. Family history is not significant. I'll stop right there.
All right. So the picture you're painting, Jomer, really it's a picture of someone with lots of like metabolic risk factors, with the hypertension, diabetes, and prior history of TIA, which kind of makes me worried about this is someone who is at risk of like vascular pathologies, especially and in the setting of like a sedentary lifestyle, makes me really wonder about like kind of his ability to ambulate. And what's in the sedentary lifestyle with someone who's like 65, it makes me worried if there's anything else that we are missing. And the other thing that just jump out to me is like kind of the long list of medication that I heard a lot of like diabetes medications that kind of point me to someone who may have like a poorly controlled diabetes. At baseline, so like a hemoglobin A1C would be helpful, and we're like seeing some sequel of like that with like kind of TIA potentially as a consequence of it. And with poorly controlled diabetes, microvascular risk factors, in addition to like kind of how uncontrolled your diabetes is, kind of a risk factor for different type of infections as well. So it would be kind of good to better understand like where does this patient lay in that spectrum. The other thing that I always like out of habit make note of is like kind of the medication list, and if there is anything that most recently started that potentially could be dealing with like a medication side effect. A lot of like diabetes medications, some like GLP-1s that can cause like slowing response to insulin secretions. A lot of these medications have like pancreatitis as a side effect. I have like nausea, vomiting, metformin being a notorious one. So it would be also good to kind of get a sense of like the timing of how these medications started in general and the presentation. That is, for me, always like is a little lower than like your no misdiagnosis. So we still want to make sure we're not dealing with any of the no misdiagnosis, at the same time, like really being careful about the medication list. Kirtan, what else is on your mind?
No, Sharmin, I agree with you. And the first point I wanted to emphasize, which Sharmin said in the last aliquot, is that must not miss causes like ACS, right? So I remember Rabi telling us once that in all the persons that he sees with abdominal pain, he gets the three tests: the pregnancy test, EKG, and post-void residual. So that, kind of shows you that how these three things are very common and you can miss it. And Sharmin like astutely pointed it out. So thank you so much, Sharmin, for reminding us that. Now, regarding the medications, I will just add what Sharmin said, that semaglutide, which is GLP-1 agonist, it can cause gastroparesis, right? It slows down the motility of GI tract, and that is one of the reasons how it affects your glycemic control. And that's also one of the principal reasons why it causes weight loss, because you don't feel hungry enough because your stomach is always full, it doesn't move nicely, right? But if something was started recently, then it makes sense. Like we often see people who somehow got semaglutide over the counter in order to lose weight, and over jealously, they went up to the higher doses of semaglutide right away. And the next day they will present with profound nausea and vomiting because of gastroparesis. But if somebody has been on semaglutide for a while, then it is little bit unusual that you would have fulminant nausea and vomiting out of nowhere. But one other possibility is that both SGLT2 inhibitors, which is the dapagliflozin in our case, and semaglutide, which is GLP-1, increases the risk of euglycemic diabetic ketoacidosis, right? So as we are discussing in the first aliquot, that metabolic causes of nausea and vomiting are very common and very frequently diagnosed just based on some basic labs, right? So in our case, we do have a risk factor of getting ketoacidosis by two means. First is what Shamin said, that maybe patient's diabetes is poorly controlled and you will get true ketoacidosis. The other possibility is that maybe patient was just sick, let's say from any kind of insult, maybe minor food poisoning, and because when you are sick, your body goes into this starvation mode. And during that time, if you are on SGLT2 inhibitors and GLP-1 agonists, then you are at high risk of getting euglycemic decay. Starvation is considered as one of the triggers for it. So I would be curious to know that what did we found in abdominal examination. If there was any focal examination finding, then we can look for the itis in the abdomen. But if there is no focal finding, if it's just generalized tenderness or something, then maybe our suspicion would be driven more towards the toxic metabolic category. So excited to see what the examination show, Omar.
All right, so this is a pretty short aliquot, and do let me know if you would want me to proceed after this. The physical examination findings showed a blood pressure of 143/81, a pulse rate of 94, respiratory rate of 22, a temperature of 36.4 Celsius, and an O2 saturation of 99% on room air. So he had dry mucous membranes and a soft, mildly tender abdomen in the left and right lower quadrants. There's no guarding or rebound, and the rest of the exam is normal.
Perfect. Thank you so much, Omar. So, friend, if we had to summarize what we have so far, we have a 65-year-old gentleman with relevant history of atherosclerotic cardiovascular disease in a way, like diabetes mellitus, hypertension, TIA, who is presenting with 1 day of nausea, vomiting, abdominal cramping, with examination finding significant for mild tenderness in the bilateral lower quadrant. So, this examination is fairly, we could say that non-focal, like you cannot jump to a diagnosis just based on that. And even the vitals, if you look at it, patient is afebrile, blood pressure is okay, saturating well. There is evidence of dry mucous membranes, which does make you wonder that patient hasn't been able to eat or drink well, and the fact that there is nausea and vomiting doesn't help either, right? So patient is definitely dehydrated. Now, what can we make of this tenderness in the right lower quadrant? So as we said that any kind of toxic or metabolic etiology can do it, but if we had to pick a structural etiology, then what it could be? Now, appendicitis in generally tends to cause right-sided pain, but we know that your peritoneum is one big cavity, right? So sometimes if you have a fluid collection in one side of the cavity, like in one side of your abdomen, it can track along the other side, and sometimes people with diverticulitis and appendicitis can end up having bilateral or abdominal pain. It's unusual, it's not classic, but it is not infrequently seen either. So that is one thing. Second thing, that sometimes if there is retroperitoneal pathology, let's say there is retroperitoneal bleed, and once that blood or kind of pus slowly tracks down the bilateral paracolic gutters and goes into the lower quadrants, you can end up getting abdominal pain there. But in our case, we don't have any classic signature of that. So for example, if somebody had aortic dissection, which ended up causing RP bleed, you would expect them to have more significant pain, or you would expect them to be hemodynamically unstable, which we don't seem to have. And similarly, if there was some retroperitoneal inflammation going on, same way you would have maybe some focal examination findings on the vertebral examination, or more pain in the epigastric region, which we don't seem to have. Like as Shamin was telling in the previous aliquot, that some of these medications can end up causing pancreatitis. And we know that pancreatitis can have so many complications. Like, so for example, if you have necrotizing pancreatitis, you can end up getting pancreatic ascites, and you can also have hemorrhagic pancreatitis. And all that excessive fluid can kind of track down at the lower part of your abdomen and can end up causing some discomfort and pain in that region. But again, we don't seem to have the classic history or examination findings for that. So as of now, I am not sure that how can we incorporate this tenderness in our thinking, but at least getting the ultrasound of the abdomen, and down the line, CT abdomen and pelvis can guide us that if there is any structural pathology going on there. What do you think, Sharmin, of that examination finding?
Oh, I have nothing to add. I totally agree with you. I think, as people get older, in my experience, the specificity of like where the tenderness is also decreases. I've just like seen cholecystitis present with like left lower quadrant abdominal pain. So I think like yeah, as I get older in medicine, I'm just like, oh, noted that there's something going on in the abdomen that requires further scrutiny. However, like how much it maps to the exact quadrant and like structures becomes like harder to discern. So I'm right there with you. I think we note the dehydration, as mentioned. Is it a nausea, vomiting, or as you mentioned, are we dealing with like kind of a DKA HHS type of a picture that could have exacerbated this the circle of like nausea, vomiting, and more dehydration? Or are we dealing with like a more infectious etiology in the abdomen? And I think like with a little bit of labs, hopefully we'll have more context to put all of your great reasoning into Kirtan. All right, Jomer, back to you.
All right. So we have laboratory results with us. The CDC showed a WBC count of 12.24 with neutrophil predominance. His hemoglobin was at 11.3 with an MCD of 87. His liver profile showed high liver enzymes, an AST of 1,603 and ALT of 2,542. The total bilirubin and direct bilirubin and ALP was normal. Renal profile showed a BUN of 77 and creatinine of 10. His sodium was at 120, potassium at 5.6, chloride 82, bicarb of 15, and calcium of 8.2. His CK was elevated at 3,147, lactate at 3.6, LDH of 371. A urinalysis showed positive for blood, but no RBCs were seen on microscopy. An ABG showed a pH of 7.42, PCO2 of 24, and PO2 57. The rest of the labs like glucose, beta hydroxybutyrate, lipase, blood cultures, COVID, influenza, AD, PCR, HIV, hepatitis A, B, C were all normal. Pretty good.
Wow. What a rich Alaka. So maybe we'll divide and conquer. Kirtan, how about I just like take the LFTs and then I'll have you layer on everything else onto it. So, with the AST ALT elevation, first starting with CBC, not to ignore the poor CBC, but, we have like a little bit of a leukocytosis and like a mild anemia. I would be curious to kind of, especially with like the mild anemia, to see how much of it is baseline for this patient with the prior labs. But this patient, whatever is going on, whether it's like the stress or the infection, has caused like a little bit of a leukocytosis. But I think the money is on the rest of the lab. So looking at that AST and ALT that are like, we're kind of dealing with like a severe acute liver injury. And whenever I think about a severe liver injury, a couple of things that comes to my mind is like, are we dealing with like kind of ischemic hepatitis, a stolen biliary tree disease that, in the setting of like elevated normal alk-phos and bili makes it a little less likely. But I always like to think that, gallbladder is a neighbor of the liver, and it can can present with like liver chemistries differences as much as it likes. And then the other things to think about are like drugs, medications, and like kind of viral hepatitis are like the most like common etiologies that I often think about. If you kind of like break that a little bit further, you can kind of think about like more parenchymal diseases that can cause issues. And that is like oftentimes like hepatitis A, B, D, E, C, like the alphabets. I can definitely do it. The other ones that you don't want to miss out on, like your HIV, EBV, CMV, that can do it. We're not like getting a flavor in terms of like any other viral syndrome except the nausea, vomiting to explain those. And then I think like the things that are like on my second pass for like kind of hepatic parenchymal diseases are like infiltrative malignancies, autoimmune hepatitis, that tend to be a little less common. And then once you think about parenchymal disease, the other thing that you want to think about are the vessels that are involved in your liver, whether it's like oftentimes we see like congestions in the form of like backup from the hepatic vein, or like Budd-Chiari, that oftentimes like the congestive hepatopathy is kind of like ischemic hepatitis that the liver is seeing. And then you can think about like hepatic artery involvement, if there's any vasospasm, any a thrombus, and then like those are the two main blood vessels to think about when you're thinking when you see AST, ALT that elevated. And in terms of the biliary issue that we've already talked about, that it seems a little less likely here. So I think like the couple of things that would be helpful in this patient is like your liver right upper quadrant ultrasound with Doppler to take a good view of the imaging, or at least if you get a CT imaging, make sure you can visualize the vessels with contrast. And then also thinking about, sending your HIV test, your hepatitis panels, as well as like again scrutinizing any toxins, any drugs that could potentially cause a severe liver injury. Kirtan, what do you have to add to that? And then what do you make of the rest of the labs?
Perfect. So no, Shavin, I agree with you that whenever we see the AST/ALT levels which cross the mark of 1,000, there are like certain reflex differences which you need to invoke. So first, like the infection. So Homer told us that hepatitis A, B, C was negative, but we still don't know if hepatitis E, like E for elephant, was tested in particular, because in fact that's the kind of hepatitis which is more common in like developing countries where there could be water and food contamination by like fecal matter, and that could end up causing this. And remember, this patient had some homemade soup, so we still don't know what happened there, right? So getting hepatitis E is a must. And other viruses also, we have seen many times that initially they are used to be the dictum that if you have like HSV or VZV hepatitis, you need to be immunocompromised. But then over the years, we have known that in reality, HSV and VZV can cause primary hepatitis without even any other cutaneous manifestations in immunocompetent people. So in somebody who we are not getting a clear answer from classic infectious serologists, we should definitely expand our horizons and include the herpes group of families. So like HSV, VCV, CMV, EBV, and HIV syphilis just as a part of routine workup if you're immunocompromised or not. The second part, so the ischemia, as Sharmin said, that you will need ultrasound with Doppler to see if there is evidence of hepatic vein issues. Hepatic arteries causing ischemic hepatitis is kind of rare, unusual, and it only happens if you are in really, really bad shock. In our case, our patient has been hemodynamically stable, so ischemia from the arterial side seems to be less likely. The third big bucket of very high AST/ALT is the autoimmune category. So things like autoimmune hepatitis, primary biliary cirrhosis, and then primary biliary cirrhosis, PSC overlap with AIH. And the age kind of is little bit older for all of those disorders, but definitely in somebody who is in this liver failure kind of state, we need to get those autoimmune serologies as well. The fourth big bucket is the toxic bucket. So if we scrutinize the medications closely, we don't see acetaminophen, which is the big toxin which can cause liver injury. Now, in general, acetaminophen toxicity presents as high bilirubin levels as well, which we don't have. So, of course, we would go to the bedside and ask the patient if patient took any acetaminophen, but from the lab profile, it kind of seems less likely. What about the statins? So we do know that statins are known to cause liver injury, and how bad can be that liver injury? That's variable. Like it depends on what kind of studies you are looking at. There are people who get AST/ALT in hundreds, and there are people who get AST/ALTs in 2000s as well. So statin is definitely something which can cause hepatotoxicity. And I guess there is a very good website. It's known as like livertox.com, it gives you a good alphabetical breakdown of all the drugs which can cause liver injury and to what extent. So statins is definitely something which I will keep on the back of my mind. And I will also get back to statins when we talk about the CK levels being high. The other important toxin which I wanted to mention was that there are some mushrooms which can end up causing liver toxicity. So we used to remember this, back in like step one examination when we were medical students, that there is like Amanita mushroom, which is one of the unique species of mushroom, which can end up causing very bad liver toxicity. And it can also cause the muscle injury. And often these mushrooms are incorporated into your food chain when you are bringing your vegetables from outside, or like preparing soup, something like that. Like in soup, some of these ingredients could have contamination with mushrooms. So it's very important to know that how was the soup prepared, and making sure that no like anomalous herbal elements were incorporated into the soup, which can end up causing such kind of injury. So that's the toxic part of it. Now if we move to the CK levels, so I will also come back to Charmaine so that she can comment on the CK levels as well, what are her thoughts. But yes, Shamik, do you wanna layer your thoughts now, and then I can add later?
Sure, I love that. Yeah, it's like 3,000, really significant. When I see elevated levels that high, one thing you want to always think about is like rhabdo, which is kind of happens to be the most common etiology. You see it in like prolonged immobilization. Oftentimes, if people have been found down, we didn't get that history from this patient. The other thing that oftentimes like very intense exertions tend to do it. However, again, I don't think we quite have this history with this patient. And then, as you mentioned, I feel like drug toxins are a good one to think about, especially statin causing kind of necrotizing myopathy, in addition with the liver injury, can definitely kind of tie those two things together. And again, I think like fibrates can do it. We didn't hear about any illicit drug use that oftentimes like cocaine, amphetamines that can do it. Infections we already talked about. Infections that again would tie those things together, like EBV is a good thoughts that oftentimes can present with both of those elevations. And the one thing to always like think about, again, I less likely in this patient, but like prolonged seizures oftentimes can present with that elevated CK, and the right host may cause some ischemic injury. And as you mentioned, with like kind of the inflammatory myopathies, are we still in more of an autoimmune? Again, the age, as you mentioned, is a bit odd, but like dermatomyositis, those type of pictures, especially if there's an underlying malignancy, oftentimes you see elevated CKs. But the degree of it, oftentimes, the degree of his CK really makes me think of either rhabdo or like kind of like drug-induced myopathy. They're like a more like genetic causes, again, as someone like 65-year-old, I'm less worried about. So I think the things that you can do, like getting a urine myoglobin, make sure you're not dealing with like kind of a muscle breakdown. We already seeing some electrolyte abnormalities, and oftentimes the electrolyte abnormalities that you see are like hypokalemia, hypophosphatemia, that is associated with elevated CK. And then kind of the autoimmune workup, as we talked about. Does that kind of like how I'm thinking through it? Kirtan, what do you have to add to that?
So no, I agree with you, Shamin, that whenever you're dealing with rhabdomyolysis without any prodromal symptoms, like let's say you have weakness going on for months and months, nothing like that, it happened out of sudden and patient doesn't even have weakness on examination, then we think about toxic causes. And like, of course, we should get the urine tox, making sure that there are no illicit drugs which can end up causing liver injury as well as muscle injury. And in the drugs, like, so we have statins, and now usually when statins are combined with like ezetimibe and fibrates, the risk of myopathy goes really high. But even when you don't combine it, the thing is that statins are metabolized by the liver CYP enzymes like CYP3A4, 2D6, and so many of these enzymes are interacted by other medications which you are taking, and also by the things which you eat. So for example, if you end up drinking like some particular kind of herbal supplement, any kind of juice, some of those things can affect your liver enzymes and can maybe stop the metabolism of statins, and then statins can stay in your system for a longer period of time and can end up causing myopathy, right? So statin can cause direct myopathy, and then other myopathy is like what Shamin was saying, is known as immune mediated necrotizing myopathy, like IMNM, in which you have autoantibodies against the enzyme which statins block, which is HMG-CoA reductase. And there are other kinds of myopathies which can happen by different antibodies, but usually they don't have association with statins. But still, I'm sure that when CK levels are this high, any hospitalist would end up sending the biomarker panel, and biomarker panel will take care of all other antibodies like SRP antibodies, which can also cause necrotizing myopathy. So that's the toxic aspect of myopathy. Some infections, which Sharmin said, like EBV, CMV, can end up causing myopathy. There are other rarer infections, like, for example, Legionella and Leptospira are two infections which are classically known to cause rhabdomyolysis and kidney injury. But in general, when leptospirosis causes liver injury and kidney injury, you also have very high levels of bilirubin. In our case, there are bilirubin levels are not that high, so kind of lower on my radar. But of course, if other infectious workup turns out to be negative, we can venture into this category of rarer infections like Legionella and leptospirosis. And similarly, there are very other rare infections like West Nile virus and then yellow fever, things like that, which can cause idiosyncratic liver injury. But we should not focus on that until we have ruled out the common infections. And for the kidney injury part, I would say that a creatinine of 10 is like really concerning. And I would like to know how much urine this patient is making, and if the patient is close to getting dialysis in certain way, like if patient becomes altered or any other signs of uremia, we should definitely think about management, like getting the dialysis. But where is this kidney injury coming from? I guess there could be multiple reasons. One of them could be the fact that patient is dehydrated. Second is that this patient has severe rhabdomyolysis, and then you can end up getting myoglobin cast nephropathy. So gentle hydration, as long as patient is making urine, maybe trying to alkalinize the urine so that you can excrete the myoglobin faster, would be some of the management tips. And if still kidney doesn't improve, then I guess down the line we will need renal ultrasound and dedicated workup for kidney injury. But as of now, it looks like it's not our main problem. The main problem is figuring out this liver issue. So excited to see next aliquot that what were the imaging studies and some of these extended serological studies show.
All right. So we do have imaging results with us. So they did a CT abdomen and pelvis, which didn't show any significant abnormality. There was no bowel obstruction seen. An ultrasound of the abdomen was also done that didn't show any liver masses or bile duct dilation. There was bilateral echogenic kidneys consistent with medical renal disease. There's no hydronephrosis. And a bunch of autoimmune markers were requested. ANCA and anti-GBM, ANA, C3, C4 were all normal. SPEP, kappa, and lambda, free light chain were all normal. IgA, IgG, IgM was normal. ESR, CRP was normal. And because of the elevated creatinine, this patient nephrology was consulted, and urgent hemodialysis was advised. And nephrology also advised that lisinopril and rosuvastatin be discontinued. And a kidney biopsy was ordered, and I will reveal the diagnosis after this.
Go for it, friend.
Yes. So, wow, very complicated case. And we have to figure out that what is the question we are trying to answer? That are we trying to figure out the cause of liver injury and kidney as a single cause, or are they separate? So first and foremost, to make sure that we are not losing sight of why the patient came. So the patient came with nausea, vomiting, and we are thinking that could it be toxic cause, could it be metabolic cause, could it be anatomical structural cause? And then fortunately, with the basic chemistries, we got the answer that maybe it's this high degree of liver injury which is driving this nausea and vomiting. So we took care of the main chief complaint. Now all we have to do is focus on the labs. And in the labs, we found out that there is fulminant liver injury. Patient doesn't have liver failure because patient is not altered. Patient's INR seems to be holding there, right? So we were wondering if this AST, ALT could be explained just from the rhabdomyolysis, or there is some degree of liver injury as well. Now, this is important to understand because when I was in med school, I used to think that AST is something which can leak from anything apart from liver as well. Like RBCs can leak AST, muscles can leak AST, but ALT is something which is unique to liver. But then over the years, like more we read, more patients we see, we realize that even ALT is not like very, very specific to liver. We have seen so many people who have like rhabdomyolysis and their ALT could be high as well. So that is one point I wanted to raise, that given that our examination is completely clean, like ultrasound is clean, CT scan is clean, nothing is turning out from the liver. Bilirubin was also fine, ALP was fine. It kind of, makes you wonder that was the liver involved to some extent at all or not at all? And even if it was involved, was it the center of gravity or not, right? So then our focus shifts to the figuring out that what caused the rhabdomyolysis. And so far, we are thinking that maybe it's a toxic cause because the patient is on some of the medications which are high risk medications. We were not able to find out any other clear evidence of infections which can end up causing such kind of rhabdomyolysis. And autoimmune serologists, like, of course, we will wait for the myositis panel if it should be done, and we will see what it showed. But at least the ANA ANCA and that part was negative. Now the question has come to the kidney biopsy, that what it would show. So I think since we just have one UA, there is not much to go from the UA, right? That at least we found out that UA had some blood in it, but no RBCs. So that kind of points toward the fact that it is coming from myoglobin. Because if there were RBCs in it, then we can think about glomerular hematuria or non-glomerular hematuria. But looks like that this could be attributed to the myoglobin itself. So now, what would the kidney biopsy show? So I was thinking that since we don't have any clear evidence of, let's say, nephrotic syndrome going on, those kinds of things like FSGS, membranous nephropathy, minimal change, probably less likely. The fact that patient has underlying diabetes and ultrasound showed echogenic kidneys does make me wonder if this patient had some degree of underlying CKD to begin with, and now there is this acute insult which is causing this. So AKI on CKD is definitely possible, because if it was just AKI, just ultrasound would not show echogenic kidneys, right? So it is possible that on biopsy we may found some evidence of diabetic kidney disease, which is fairly common. The other thing is that what could be the acute insult on the diabetic kidney disease? So that could be, as we said, it could be myoglobin cast nephropathy. So maybe on biopsy, we will see the evidence of this myoglobin cast stuck inside the tubules. The other rarer possibility, although it's less likely, but I am just going to mention it because of diabetes, that people with diabetes can have something known as papillary necrosis, which means that both the renal papilla can end up getting necrosed, and it would end up causing flank pain similar to the nephrolithiasis, and people have true hematuria. We don't have hematuria in our case, so that is less likely. Given that paraproteinemia workup was unremarkable, at least the SPEP and free light chains, the monoclonal gammopathy of renal significance or myeloma kidney seems to be less likely, and we don't have any other systemic evidence of paraproteinemias in our labs so far. So yeah, that would be my guess, that maybe it will show acute tubular necrosis from the myoglobin on the background of diabetic kidney disease. What do you think, Shamin? What other kidney stuff we should think about?
Yeah, I totally agree with you. As we were going through the case, didn't, I don't think like I might be completely wrong, but the kidneys are the center of gravity. I mean, kidneys are awesome. I'm a big fan. But to me, it was like that elevated CK and the liver chemistry, the liver chemistry abnormality. And the point you made was a really excellent one about seeing AST ALT elevation and setting up like a really severe like CK elevation, that things are bursting and you're seeing that. So for me, I think like the answer to question lies on like what is causing that CK to elevation. And it is a really good case for like kind of that statin induced kind of necrotizing myositis and something like oftentimes with rhabdo people have like really severe muscle pain. With statin induces a little less oftentimes. So I think that is like the question I'm trying to answer is like, okay, what caused that underlying CK elevation? And there's a good, as you mentioned, like a mechanism that would explain why you're seeing the kidney injuries and likely in the setting of someone who has had history of diabetes and CKD in the past, this is something that tipped them over. I'm so excited to learn if you're missing something in our reasoning, but it is a good it was a good case for like kind of a toxic mediated or medication mediated um, ideology, because I can't think of anything else. Kirtan, you're the expert that would like tie in like severe kidney injury, like like none of the autoimmune diseases other than like necrotizing myositis type picture is really uh, is being triggered for me. Anything else that you were thinking of?
No, I agree with you, Sharmin, that any other infections which can end up causing liver and muscle damage, but then we don't have the classic risk factors. We don't have like fever or patient is not in shock. Like leptospira can sometimes cause rhabdomyolysis and liver injury, but then as we said that bilirubin is not really high and patient is not sick. People with leptospirosis tends to be very, very sick. So I agree with you that it kind of looks like that is the rhabdomyolysis which caused the kidney injury, like myoglobin induced, and rhabdomyolysis was triggered by the toxin stuff. And of course, we'll wait for the myositis panel, what it showed. And yeah, that's where I am. Let's see what the biopsy showed.
So the surgical pathology of the left kidney showed mesangial hypercellularity with matrix expansion, severe interstitial fibrosis, and tubular atrophy. And the arteries had moderate to severe intimal fibrosis, and the arterioles showed severe hyalinosis. So all of these findings are consistent with diabetic glomerulosclerosis. However, the tubules were also markedly thickened and wrinkled, and the tubular lumen showed many pigmented casts and detached epithelial cells, and there was positive myoglobin staining for the pigmented tubular casts. So the final diagnosis is AKI, secondary to myoglobin cast nephropathy, superimposed on chronic diabetic kidney disease.
That is awesome, Jomer. What a really informative case. So any what did you guys think caused that elevated CK? Do you think it was like mostly immobility, any toxin, any other insight in regards to that?
Yeah, so our team was thinking that this patient lives a sedentary lifestyle, so this is most likely a non-traumatic cause of the rhabdomyolysis. So the only thing that could attribute it to was the statins that he had been taking for so long. There wasn't any recent changes in the dosage, and that was what was most puzzling to us was that he had been on the statins for close to a decade, actually. It was started when he had a TIA 10 years ago. And he'd been on that same dosage for so long. And it made us ask why now all of a sudden? And I did some research on it, and it says that statin-induced rhabdomyolysis is, I mean, the incidence of that is pretty low. However, the risk increases when there are certain predisposing conditions that arise, like volume depletion, metabolic acidosis, ischemia. I unfortunately didn't get to speak with the patient again to ask them whether he'd been dehydrated or, previously before that, or if he had been limiting his fluid intake on the days prior. But an interesting thing that I did see, because it's pretty contentious for us too, that this is rhabdo because the CK is at 3,000-ish, and we were expecting for it to be higher. But apparently creatine kinase peaks within 24 hours of muscle injury. And thereafter, about 50% of that declines every 48 hours. So what we were probably, well, our assumption is that the muscle injury had occurred perhaps days before that, and we had done the blood test at a point where the CK had already declined to a certain extent. So this is a very interesting case for our team. Because personally, this is the first time I've seen a case like this. When I think of statins, I think of myopathy, within the first few weeks or months of starting them, but something, rhabdomyolysis arising like a decade after, having been on this medication was the most surprising.
Wow, like such a fascinating case. Thank you so much, Jomer. Kirtan, what are your thoughts?
Yes. Sure. Thank you, Homer, again for presenting the case to us for the first time, and we would love to have you again and learn from you. And I agree with you. This statin part is very mysterious. And to be honest, since we have time, I can say that it's very nostalgic because the first case which I saw in residency, I still remember it was like maybe July 5th, 2022, because first 4 days was some orientation or something. And I was in GI service, and they reached out to us with the concept of drug-induced liver injury, and patient's AST/ALT was like 200 or something, but the patient's LDH was like 1000. And that's when, although we were in GI service, we did recommend that, hey, like the LDH is too high. We think that this AST/ALT could be coming from somewhere else. And then we ended up getting CK. And as you said, that it peaks in like 24 hours or so. So in our case, the patient just came like 1.5 day after feeling whatever patient felt. So patient CK was like 12,000 at that time. And then we followed it every single day and it kind of went down. And that case eventually turned out to be statin-induced necrotizing myopathy because the patient's HMG-CR antibodies returned positive. And again, the same story in that lady, no recent nausea, no vomiting, no change in the doses. Patient had been on the stable dose of rosuvastatin for like 5 years. So apparently, as it turns out, that your body just reached a certain point and you end up triggering this autoimmune myopathy, and it just happens. So sometimes it's just idiopathic that we cannot find a trigger for it. But yeah, statins are notorious, and that's why I always worry that I give statins to my mom. And what if my mom has something? So I always worry because of such cases. But no, thank you again for bringing such a wonderful case, and thanks to Sharmin. Like Sharmin was the one who, like, as soon as she saw the medications, and she was the one like, yeah, it looks like necrotizing myopathy. It causes abdominalitis and stuff. So always a top-notch discussion with Sharmin. Learned a lot. Sharmin, any final teaching points before we move to one more, please?
I agree with everything up until your comments on me. Everything else, I totally agree, Kirtan. Jomer, we would love to have you back. This was awesome. Kirtan, absolute pleasure. It's just been such like joy to see you like throughout all the years, and just you're such a wonderful diagnostician, and your passion for medicine is just infectious. So I always like appreciate being around you, and how you think through medicine and how much time you dedicate in perfecting this art is like truly inspiring. I learned a ton. I have much to reflect on, as I always do. But thank you so much, everyone. Really appreciate your time. And Amol Preet, to you for the teaching points.
Wonderful case and great discussion. I had a great 1 hour. So to just summarize some of the teaching points, the first thing we discussed about is recall bias. So this patient presented with the complaints of vomiting after he had that homemade soup. So that's what we discussed, that sometimes if we have a symptom after doing certain thing, we tend to associate the symptom with that thing, but they might not be associated. So that's what actually turned out to be in this case as well. So number one point was regarding recall bias. Then we started discussing about the causes of vomiting. We can have metabolic causes as well, in which some examples we can give is diabetic ketoacidosis or uremia. So we can send electrolytes in this case to understand if the vomiting is caused by any metabolic cause. Number two, we can think about toxins. So for example, if it is actually related to the food he ate, so it could be food poisoning due to Staph aureus or bacillus. We can get bacillus if we reheat rice, so bacillus grows in that. Then we can have drug-induced side effects. This patient was taking multiple drugs. So some drugs can have side effects which can present with vomiting, just like, and we can actually ask if the patient has started with some new medications, and even the history of old medicines is important as well, as we saw in this case. And then any obstruction in the GI tract can cause vomiting, for example, acute esophagitis, gastritis, small bowel obstruction. Any problem with vestibular system, so we can ask for some other symptoms as well, maybe related to the ear or vestibulocochlear nerve. Then we can think about brainstem issues. Any mass or any stroke can lead to these symptoms. Any cerebral cortex issues, which can lead to the things which can lead to increased ICP. Any acute intracranial catastrophe, which can lead to these things. And ultimately, we discussed that even cardiac issues can present with vomiting because of the vasovagal symptoms. We also realized that the patient was having abdominal cramping. So we always have to rule out VIPO in abdominal pain. So we can ask simple questions like if they're able to pass platters or not. So it's important to rule that emergency causes out before we step out to the other causes. Now we understood that the patient was taking semaglutide, that is a GLP-1 agonist. And how does it work? It causes gastroparesis, and that's how it contributes to weight loss as well. But it can present with vomiting too. So that is one of the cause. And then we have the patient on Farxiga, that is dapagliflozin. Dapagliflozin can lead to euglycemic diabetic ketoacidosis. That is an important cause which we need to consider as well. And then we discussed about the causes like the diverticulitis and appendicitis. It has classical pains, like diverticulitis can present with left-sided pain, appendicitis can present with right-sided pain, but in certain cases, it can have a non-classical bilateral abdominal pain as well. So we realized this patient was having severe acute liver injury in the labs. There were multiple abnormalities in the lab. One was this. The liver enzymes were more than 1,000. So it has some set certain causes. So one of the causes is ischemia, where the problem with the vein, hepatic vein, can lead to the liver injury. Number two, it can be viral hepatitis, which can be due to Hep A, Hep B, Hep C, Hep E, and other herpes viruses like HSV, VZV. Then toxins can lead to acute liver injury. Toxins, we can divide it into drug-induced, which can be acetaminophen, which has biliary elevation as well, and statin-induced liver injury. And then the next category of toxins is mushrooms, or maybe some other toxins like mushrooms, which can include amanita, that can lead to liver injury. And then autoimmune causes as well, they can also cause the liver injury. Then we also realized the patient is having elevated CK. So what could be the possible causes? Rhabdomyolysis, severe exertion. Toxins come here as well. So number one is statin. If we combine statin with ezetimibe and fibrates, it increases the risk of myopathy significantly, but statins alone can contribute to the myopathy. So we see some of these common causes which can lead to liver injury and elevated CK. So we have to focus on that. And mushrooms as well can lead to the similar findings. Some infections can lead to elevated CK like leptospira, Legionella, EBV, CMV. Prolonged seizures, inflammatory myopathies, and genetic are some of the other rare causes which are lower down in the differentials in this patient. Then we saw this patient was having severe kidney injury. So it was important to know what was the baseline creatinine in this patient, as we were thinking that the diabetes is uncontrolled. So diabetes can lead to some microvascular complications affecting the nerves, eyes, causing retinopathy, and it can also lead to end-stage renal disease. It leads to nephropathy as well. So it's important to know if the patient's kidney is already injured or not. So the baseline creatinine is important, and now the creatinine is 10. So we have to look out for the indications of dialysis if the patient is entering severe acidosis or uremia is happening. So we have to emergency dialyze the patient and call nephrology. This kidney injury can be secondary to rhabdomyolysis, dehydration, so it is multifactorial in this case. And we discussed that diabetic patients can have renal papillary necrosis as well, along with diabetic kidney disease as a microvascular complication. Ultimately, we realized that the statins were most likely responsible, and it caused all of the problems leading to uremia on an already injured kidney, and myoglobin elevation. So thank you so much. I have got a lot to read on this. I enjoyed a lot in this 1 hour. Thank you very much.
Oh, that was absolutely brilliant and so thoughtful and so thorough. Beautiful job, Amalpreet. Team, this was awesome. Thank you so much for joining us. Jomer, we can't wait to have you back. And shout out to everyone. Thank you. Bye.